All right, well, good afternoon, everyone. I am pleased to welcome you to the Hemoptysis, What You Need to Know webinar with Dr. Mark Metersky, Chief of the Division of Pulmonary, Critical Care, and Sleep Medicine of the University of Connecticut School of Medicine. My name is Christina Hunt, and I am the Director of Bronchiectasis and NTM Research and Education at the COPD Foundation. I will be your moderator today. This webinar is being recorded and will be made available for future viewing. Before I get started, I wanted to mention that we will be muting your microphones throughout the presentation. If you are new to the Zoom platform, you're going to notice a bunch of icons down at the bottom of your screen. Throughout this webinar, we're going to leave your mics muted, but if you have any questions that you would like our expert to answer, I invite you to use the Q&A feature to submit them. You do so by clicking on the Q&A icon and entering a question in the box. We will try and get to as many of your questions as we can by the end of the presentation. We would like to thank our partner, NTM Information and Research, for joining with us to organize and plan this webinar. This webinar is being held in honor of World NTM Awareness Day. On August 4th, just last Friday, the inaugural World NTM Awareness Day was celebrated and will continue to be observed annually. World NTM Awareness Day aims to raise awareness on the resources available to patients and increase early testing to avoid delayed diagnosis. We would like to thank our community for their support of World NTM Awareness Day. And if you're curious to learn more, I invite you to visit worldntmday.org. We have two upcoming events that we would like to share with you. On Wednesday, tomorrow, August 9th at 3 p.m. Eastern, Bronch and NTM 360 Social will be hosting its monthly coffee break. To register, visit Bronch and NTM 360 Social. Then on Saturday, August 26th, at 3 p.m. Eastern, NTM IR will be hosting a meal planning webinar. To register for this event, go to NTM Connect. And without further ado, we will begin the webinar. I want to start out by introducing our presenter today. As mentioned, Dr. Mark Metersky is Chief of the Division of Pulmonary, Critical Care, and Sleep Medicine, and the Director of Bronchiectasis Care Center at the University of Connecticut School of Medicine. He serves as Chairman of the U.S. Bronchiectasis and NTM Research Registry and recently joined the COPD Foundation Board of Directors. He has been involved in and authored numerous studies, trials, and publications regarding the treatment and identification of bronchiectasis and NTM lung disease. Welcome, Dr. Metersky.
Thanks, Christina. It's a pleasure to join everybody and see so many people interested. Okay, it's going to allow me to share my screen, which is good. And let me move the talk over and go to presentation mode. All right, is it showing up?
Oh, yes, I can see it.
Okay. All right, so let's get going. Oh, this is the wrong version. I apologize for that. So I had a slide with my disclosures in terms of relationships. I've done some consulting for several pharmaceutical and device companies, including Insmed, Boehringer Ingelheim, Tactile, AN2, and Renovion regarding bronchiectasis, NTM, and not regarding hemoptysis. So really nothing that I've done relates to hemoptysis. So let's start with defining what it is. That's always an important thing to do when you're giving a talk. And most of you are probably aware that hemoptysis means coughing of blood from a lower respiratory source. So it's not a nosebleed or bleeding from the throat. It really means that the blood is coming from the airways or the lungs. And therefore it excludes pseudohemoptysis or false hemoptysis, which is the coughing up or clearing of throat of blood from sources such as the GI tract, the nose, or the mouth. And it's often surprisingly difficult to determine the difference from what the patient tells you. It's not unusual that the patient isn't real clear on whether they're coughing it up or vomiting it up or clearing their throat or it's coming down from their nose. So that's always the first step with a patient with possible hemoptysis. So there are numerous causes of hemoptysis, probably only one of which is of interest to most of the people on this call. But when we as clinicians see patients with hemoptysis, once we've determined that that's what we're dealing with, we really have to go through the list in our mind to make sure that we get it right, because just because someone has bronchiectasis doesn't necessarily mean that that's where their hemoptysis is coming from, although usually the case. And when I say bronchiectasis throughout this talk, I'm referring to bronchiectasis and NTM that may cause bronchiectasis. But in my experience, it would be a little unusual to have hemoptysis related to NTM without damage of the airways from the NTM that shows at least a little bronchiectasis on the CAT scan. But the most common cause is probably bronchitis, either acute from a viral infection or more chronic from tobacco smoking. The one thing we never want to miss, oh my Lord. Okay, the one thing we never want to miss is lung cancer, because if we wait too long with that, then the cancer can spread and be incurable. We can also see tumors that are metastatic from somewhere else that end up in the airway that can cause hemoptysis, or benign growths such as a carcinoid is the most common cause in the airways that can also bleed. Infection separate from bronchiectasis or NTM can cause hemoptysis. So necrotizing, what necrotizing means is in the setting of a pneumonia is a pneumonia that's severe enough that lung tissue is actually being destroyed. And that is actually not the case for most pneumonias. Most pneumonias don't destroy lung tissue. They cause a lot of inflammation. They cause a lot of discomfort and problems, but the lung tissue is usually spared. And most patients will go back to having a normal chest x-ray or CAT scan even after a pneumonia. But certain organisms actually elaborate toxins or cause so much inflammation that the lung is actually damaged permanently. And when you have this disruption of the integrity of the tissue, you can get hemoptysis. Mycetoma is a fungus ball, literally a ball of fungus in a pre-existing cavity. So that's relevant to patients with NTM who may have cavitary disease. And the fungus can take up residence within this cavity where it has everything it needs to grow. And the inflammation that it causes, as well as just the mechanical damage from this fungus ball literally rolling around in this cavity, can cause hemoptysis. A fungal infection where the fungus is actually invading into the lung tissue. And tuberculosis can cause hemoptysis both by causing direct damage to the airways or from something called a Rasmussen's aneurysm, where the tuberculosis destroys some of the lung but leaves a vessel sort of literally hanging in midair in that area of destroyed lung in that cavity. And that vessel doesn't have supporting tissue and is therefore fragile and susceptible to rupturing. The list goes on. So pulmonary vascular conditions such as a pulmonary embolism or a blood clot to the lung can cause hemoptysis. Arteriovenous malformations, which I'm going to show you a picture of. Basically, it's an abnormal collection of blood vessels that can be fragile and can bleed. Pulmonary alveolar hemorrhage refers to a set of conditions where the bleeding is way far down in the alveoli, those grape-like sacs where gases are exchanged. And very often they're autoimmune or toxin mediated. You can have anti-basement membrane antibody or good pastures, which can also cause, it's sort of the classic cause of pulmonary alveolar hemorrhage, where you have antibodies that attack the lung tissue in the alveolar area and therefore expose the capillaries to bleeding. Just like a pipe is more prone to leak when it's under high pressure, so are the capillaries in the lungs. So heart failure, which is sort of cause and effect of high pressures in the blood vessels, can do it, or a blocked valve, just like the pressure will go up if a pipe is blocked, if someone's pumping through it. Same thing can happen in the heart, which causes higher pressures behind that mitral stenosis, that tight valve. Antiplatelet and anticoagulant medications. Many people are on these medications. Antiplatelets are for patients most commonly have had strokes or heart attacks or angina, so coronary artery disease, and anticoagulant medications for people who've had prior blood clots. Obviously, they lessen the ability of the blood to clot. So if you have anything that makes you prone to bleeding, it's going to potentially tip it over into actual bleeding or make the bleeding worse than it otherwise would have been. And then there are some intrinsic disorders of coagulation, whether it's liver disease, so you don't have clotting factors, or things that cause low platelets that can contribute in the same way. And then obviously trauma, blunt or penetrating trauma, medically induced trauma such as biopsies. Sometimes we put catheters into the pulmonary arteries and those can damage the vessels. And then there is something that I'm going to bet most of you have never heard of, thoracic endometriosis. So patients can have uterine tissue that we believe migrates through the fallopian tubes, through the belly, and up into the chest, into the lungs, although it may be spread by blood. It's not completely clear. And just like women who have their cycle, this tissue can bleed on a monthly basis. So that's always a sort of fascinating cause of hemoptysis that shows up on tests, when someone has intermittent bleeding on a monthly basis. I've only seen one case in 30 some years, so it's not that common. So this is a tumor growing in an airway. You can see it's a hollow tube. And you can imagine that this fairly scary looking blood vessel here, which isn't protected by any tissue, it's on the surface, might bleed if it gets annoyed, if it gets irritated by something. Certainly, if I was going to biopsy this with a bronchoscopy, my forceps would be going here, not anywhere. I assume you can see my cursor. This is an AVM. So these are normal blood vessels. So the pulmonary artery that goes down into the capillaries where gases get exchanged because they're very thin-walled, and then back into the pulmonary veins. And a simple AVM is when there's an abnormal connection. So the capillaries aren't there, and you have this connection between the arteries and the veins. And this vessel, which generally isn't equipped to handle the higher arterial pressure, can rupture. And then you can have complex one, which is just like a nest of snakes, again with abnormal connections and prone to rupture. This is a CAT scan, patient who has a cavity outlined here by that sort of thin rim tissue. This may have been old tuberculosis. It may have been an old pneumonia that was necrotizing. It could be NTM, although I don't see any other evidence of NTM. But this white density in the middle of it is a ball of fungus. And it's loose in there. Quite literally, it can roll around. And before CAT scans, radiologists or doctors, pulmonologists would prove that a density like this was a mycetoma, a fungus ball, by taking pictures, x-rays in different positions, and you could see that the ball would change position. It would move with gravity. Let's see, I'm going to minimize this or actually move it out of the way. This is a dilated blood vessel with contrast in it. So this is probably an AVM. Again, this blood vessel sort of hanging out there, ready to rupture if anything disturbs it. So this is a patient, and I wanted to show you why patients with bronchiectasis, although this isn't a bronchiectasis patient, this is an AVM patient. These pictures of the blood vessels show what I want to show. So the question is, why do patients with bronchiectasis and NTM have hemoptysis? Well, chronic inflammation results in substances being released that stimulate blood vessels to grow into that area in an attempt to cause healing. And so you get these abnormal vessels. And if you look at panel E here, the normal vessels, when you look at an angiogram, so there's dye in here so you can see the vessels, there aren't hundreds of vessels that are big enough to see on angiogram in a normal lung. But what you can see in patients with chronic inflammation from chronic NTM or bronchiectasis sometimes is these nests of blood vessels. They're not AVMs, they do end in capillaries, but these are abnormal vessels. They've grown into the area. They're not supported by the normal connective tissue. They're not protected, and they therefore are fragile. And this is what I just mentioned, the chronic inflammation and the new blood vessels. So when we talk eventually about how to treat hemoptysis, it's important to understand that we're born with a little bit of extra blood supply to the lungs, and we can sacrifice some of that if an area is bleeding by safely. So normally, if you lose blood supply to a part of the body, that part of the body dies unless the blood supply is brought back. But the lung tissue gets its oxygen 3 ways. There's the pulmonary circulation, which is the most blood flow. Basically, the entire blood flow of the body goes through the aorta and out to the rest of the body, and it comes back into the veins and then gets pumped through the lungs, and then gets oxygenated and then comes back to the heart so it can go back out to the body. So that's the pulmonary circulation. And that's a low pressure circuit. It's probably about 1/4 to the 5th as much pressure as your normal blood pressure of 120/80. Pulmonary pressures are 20/10. So much less. So these vessels are not built to take high pressures. Then there's the bronchial circulation, which comes off of the aorta and is at the normal pressures that we consider when we talk about blood pressures, 120/80, something like that. And that supplies oxygen to the tissue of the lung, mostly the bronchi. All right. This is a high pressure circuit. And therefore, very often, most often, when patients have hemoptysis, especially if it's coming from the airway, it's the bronchial circulation. And then, of course, from breathing, much of the lung gets oxygen just from it coming in and out of the lungs, not even through the blood supply. And the key point here is that these bronchial arteries, which are most commonly the culprit for bleeding, we can sacrifice them. If that's the cause of bleeding, we can block those arteries, and I'll eventually get to tell you why. But and it's not going to cause the tissue to die, right? If I blocked all the blood flow going to your leg is going to die. But not the case for the bronchial arteries, because they get oxygen other ways to the bronchi. Now, we classify hemoptysis not only based upon the cause, but the severity. However, every paper you read has a different definition of mild, moderate, or severe, but this one works for me, and has been accepted by at least some experts. So mild would be less than 30 cc's, which is about an ounce in 24 hours. Something like this is not going to be life-threatening, with one caveat. We quantify the blood based upon how much the patient coughs out and shows us or estimates. But the blood that the patient has coughed out isn't what's going to hurt them. It's the blood that doesn't get coughed out and sort of leaks back into the lungs and causes, depending upon how much it is, it's like drowning. Obviously, for the vast majority of patients, that doesn't happen, but the analogy is accurate that if your lungs fill up with blood, it's similar to filling up with water and you can't breathe. Moderate is between 1 ounce and about 7 or 8 ounces in 24 hours. And severe, depending upon who you read, is greater than 200 or 600. So 600 cc's would be, a pint and a half, pint and a quarter. And quantification is difficult, especially when you ask patients how much blood they coughed up before they came to the hospital. I always ask them, did you soak a tissue? Did you fill up a small cup halfway, a quarter of the way? I try and, instead of having to estimate the volume, have them use, describe how much, and then I can make the estimate. And some experts, instead of saying mild, moderate, or severe, they will talk about life-threatening hemoptysis when appropriate, instead of attempting to quantify the amount, because if you have completely normal lungs, you may tolerate 600 cc's of blood that has leaked back down into your alveoli, into your lung tissue without any difficulty. But if you have very, very bad emphysema, let's say, that 600 cc's could put you in a lot of trouble because that lung is no longer functioning. Other reasons why quantification is difficult is it's very alarming to cough up blood, and almost invariably, if it wasn't measured, it's usually exaggerated. Blood looks worse than it is usually, luckily. And then even after arrival, quantification should be easier, but blood can be mixed with saliva, sputum. It may not all get into the cup, or the cup may get thrown away. If the patient is using suction, that can get mixed with other liquids. So should be black and white, but it's often difficult. I mentioned it a little bit. Why is it life-threatening? Generally, patients are not exsanguinating. They're not dying from loss of blood. In the very, very rare case that hemoptysis is that severe, but it's killing people, again, in these very rare cases, because their lung is filling up with the blood and can't exchange gas. So checking serial blood counts rarely is helpful, because usually the patients aren't coughing up enough blood. They're not bleeding enough that their hematocrit and their hemoglobin level are dropping. So as I mentioned, the main threat to life is filling up the alveoli, but it can also be threatening if clots form in the major airways, blocking air entry. So if you get a big clot in the main bronchi and no air can get by, even if the lungs themselves further down are not filling up with blood, you're still going to have problems. So again, I've, a lot about serious or life-threatening hemoptysis, but it's only around 1 in 50 patients who present with coughing up blood who had severe. And among the severe patients, most survive. So death from hemoptysis is very unusual, and that's important for people to remember, because obviously it's alarming to cough up blood. So what about more directly related to bronchiectasis and NTM? Why do patients with these conditions cough up blood? So we've mentioned the inflamed airways with the neovascularization. New vascularization is blood vessels. So as I discussed, the blood vessels grow into the area of chronic inflammation. Rarely a fungus ball can form in a cavity from prior NTM infection. So that's always something that we think about and look at the CAT scan closely for that. And then, of course, it could be an unrelated cause. Most patients with bronchiectasis and NTM are older. Some have smoked, and therefore they're at risk for other things such as lung cancer. So again, the vast majority of cases are mild and non-life-threatening. Rarely can be life-threatening. It's not always predictable who's going to have life-threatening hemoptysis, but I think a good rule of thumb is if you don't have severe bronchiectasis, so a lot of inflammation, very bad on CAT scan, loss of lung function, you're unlikely to have severe hemoptysis. That's not 100% obviously, but nothing in medicine is. But certainly in my 30 years in this, I've not seen severe hemoptysis from bronchiectasis in patients with more mild disease. All right. So what do we do to figure out the cause in someone who comes in coughing up blood? And how we approach it certainly depends upon the severity, the chronicity, and the known relevant underlying conditions. If it's a never smoker, patient who never smoked with known severe bronchiectasis, suffering from an exacerbation, so I know there's even more inflammation going on, it was blood-tinged sputum only, and it goes away with treatment with an antibiotic, that may be all I do. However, certainly if it persists or it's more than I would expect for someone with milder bronchiectasis, anything that sort of alerts my radar that it's just not quite what I would expect, then I'm going to do more testing. Almost always a sputum culture, a complete blood count, because we just want to see where the blood count is starting in case it becomes severe. Coagulation tests. Does this patient have a problem that causes them not to clot well? And imaging, such as a chest X-ray or a CT scan. And the more blood they're coughing up, the greater likelihood of the imaging being useful. I mean, it's not unusual for me to get a call from a patient with bronchiectasis saying, you know, I'm sick, I'm coughing up more sputum, it's green, you know, it's normally white, and I'm having some blood-tinged sputum. I'm not doing any testing, almost surely. I'm going to give them an antibiotic, and if it goes away, we're done. If it doesn't go away, then clearly I'm going to need to do more investigations. Bronchoscopy is usually done for the first episode of more than minimal hemoptysis, and even minimal hemoptysis, if it persists, I'm going to do a CAT scan and almost always going to do a bronchoscopy because I don't want to miss an early tumor, whether it's benign or malignant. Now, now, someone who has recurrent hemoptysis, let's say once a year they have an exacerbation of their bronchiectasis and every time they cough up a little bit of blood, I am not going to do a bronchoscopy every time. Most patients end up getting bronchoscopy with their first episode just to make sure there's nothing else going on. But unless there's a change in pattern or change in imaging, we're not going to do bronchoscopy every time they cough up blood. That would just be too excessive with a very low yield of finding something important. So let's move on to treatment. And as I alluded to, if it's mild and temporary, it may just be an antibiotic. In most cases, this is a question that comes up often. If they're doing patients on vest or a cappella or aerobica that causes the vibrations, we generally will hold the airway clearance until the hemoptysis resolves. Now you can see there I have sedation. We don't sedate patients because of hemoptysis unless it's so severe they're on a ventilator or something like that, which again is rare. We used to be, the sort of standard treatment would include codeine for cough suppression, and perhaps it was more useful not in suppressing cough because codeine is not very effective in suppressing cough, but just sort of sedating the patient so that there's less urge to cough, helping them sleep when they're going to also cough less. Why would we want less cough, at least in theory? Because coughing can cause the kind of irritation that can make the bleeding start up again. It can remove the clots that's preventing the bleeding, just like when we cut ourselves, on our hand or whatever, the clot, if you push off the clot, you're going to start bleeding again. We're going to eliminate medications that impair clotting if they're no longer needed. So aspirin that is sort of being taken frequently for cardiovascular risk, if there's not a really strong indication, we would want to stop that. NSAIDs such as ibuprofen, Celebrex in that family, things like that impair clotting. Of course, anticoagulants, blood thinners, if they're not needed, then we're going to stop them if possible. So for severe hemoptysis, patients, of course, get admitted to the hospital. We're going to almost always do a bronchoscopy to identify the source. And with that much blood in the airways, very often we can't identify the exact source, but even finding the left versus the right can help us if we need to do certain treatments that I'm going to go into. Respiratory support, intubation with a breathing tube and mechanical ventilation as needed. We have special tubes that, again, very rarely, but we could use that. One goes into the right lung and one goes into the left lung. So if the right lung's bleeding, it isolates that lung and the blood coming from there and prevents the left lung from getting drowned. So you have one good lung left. We always want to position the bleeding side down if it's severe and continuing, again, to preserve the good lung so gravity doesn't take blood into it. We're going to fix any clotting problems. If they have, let's say, liver disease and they're not making clotting factors, we're going to give them those clotting factors by transfusion. There are also medicines that are antifibrinolytic, so they make the clot more likely. They get rid of our body's intrinsic system that breaks down clots, even as they're forming. And then I mentioned the tubes that can go into one versus the other lung, single lung ventilation. Through the bronchoscopy, we can do other things. We can suck, other than finding the cause, we can suction clots to open airways. But the risk there is a patient who stopped bleeding or slowed down, and you suck a clot out, then you may start them bleeding again. So you always have to decide, do I really need to suck this clot off? If you don't, you leave it there and let the body's own system get rid of it. But again, if the whole trachea is completely clotted off and you can't get oxygen to the patient, then you're going to have to take that chance. Ice saline lavage is sometimes used. The cold temperature causes constriction of the blood vessels and may help stop bleeding. Just like when you or your kid was in very cold ocean water, the lips get blue. Why do the lips get blue? Because the blood vessels from cold water cause constriction to preserve heat. There are also topical medications that cause blood vessels to constrict. Epinephrine or adrenaline is one of them. You can place a bronchial blocker or a balloon in the lung that's bleeding, again, to isolate that and allow the good lung not to get drowned with blood. And then if you see a certain type of lesion, like a tumor or a bleeding vessel, you can ablate it. So you basically coagulate it with heat energy, it could be a laser, radio frequency ablation, basically to clot that area. So there are a lot of things you can do through the bronchoscope to try and both diagnose as well as treat. And there's two types of bronchoscopy. There's flexible and rigid. So flexible is thin. It can be done without any anesthesia, although generally there's no need to do it without any anesthesia, but that can be done because it's fairly thin, thinner than a standard pencil. The advantages of it, it's widespread availability. Every pulmonologist is competent for that. You don't need general anesthesia, and you don't want to anesthetize these patients, put them to sleep if coughing is the best way for them to get blood out, so it's not going down into the lungs. Anesthetizing them, if not absolutely necessary, is not the best thing to do. And you can get further down into smaller airways with this than the rigid bronchoscopy. You can see these are much, much bigger. Disadvantages, the suctioning, because it's a much narrower port, is less robust. So it can get clogged. The bleeding can overwhelm the suctioning. So even if it's not clogged, there's just too much blood and you can't see anything. All you see is just red, which is really having, had that happen. It's very frustrating. You can't do anything. You can't see anything. And generally it's harder to do these ablations that we talked about. Generally you can't do that through flexible. So then there's a rigid, and it's rigid. It's a metal pipe. So the neck has to be extended so you have a straight line. It doesn't bend, so you can't go around corners to get into smaller airways. Most pulmonologists are not expert in this. There are some that are, so it's not as available. You can't get into the smaller airways, although what you can do is you can sometimes, if you're using a big enough rigid bronchoscope, you can put the flexible through it and then get into the smaller airways. The advantages is you can suction much more, as you can imagine, through a bigger hole. So you get better visibility, and there's certain interventions like the ablation that you can do. And then for recurrent hemoptysis that impairs the quality of life, even if it's not severe, or for acutely life-threatening hemoptysis, we do bronchial artery embolization. So basically a catheter is snaked up through the groin, through the aorta, into the bronchial artery. And you can see that this is the bronchial artery. It's coiled. There's a little bit of black stuff, meaning the dye is leaking out. The patient's still bleeding. And then you can deploy metal coils, although generally not a coil, although they did in this one, or small particles. Previously, they also used literally super glue, the ingredient super glue, basically to clot off that vessel. And you can see that's what they did here, right? Here it's a long, tortuous vessel. It's gone now because they instilled something to basically clot off the vessel, and no more bleeding, right? This black blush of dye and blood is gone. It's really effective, 85 to 90%. If you have ongoing inflammation, obviously new vessels can grow back, so it might recur in 2 to 5 years, about 20% do. The other thing you can do if bronchial artery embolization isn't enough is you can surgically resect a portion of the lung where it's bleeding. Generally, it can be done through scopes inserted between the ribs. They look sort of like the rigid bronchoscope. But you only remove a portion of the lung that's the source of bleeding. So you really need to know exactly where they're bleeding from. Bronchial artery embolization, because these bronchial arteries we can do without, in theory, you can not know anything and just do both the left and the right lung. If you know it's the right lung, you just embolize the right bronchial artery, and you don't have to know exactly which part of the lung. So again, the most important point, it is alarming to cough up blood. It is very rare for it to be life-threatening acutely. And I think we can take questions now.
All right, Dr. Metersky, it looks like there's quite a few in the Q&A.
All right, I see 5. Do you want me to do this on my own?
Oh, I can read them off to you.
Yeah, I got them right here. I think that's easier.
Okay, perfect.
Are there different levels of bronchiectasis? There are certainly different levels of severity. There is a tool, a questionnaire, if you will, that does rank patients in terms of severity based upon a bunch of factors like how bad it looks on CAT scan, how old they are, how good or bad the lung function is, what bacteria they're infected with, like Pseudomonas is worse. And you come up with a number, and then depending upon the number, you're mild, moderate, or severe. Hopefully that answers the question. What are the main causes of shortness of breath or labored breathing? In a patient with bronchiectasis, it's usually due to what we would call airways obstruction, meaning the airways are floppy. So when you breathe out, they collapse, and therefore more air is retained in the lungs, and it's harder to breathe in. Think of an asthmatic, similar to that, only with asthma, it's active tightening of the airways as opposed to collapse. Obviously, in patients without bronchiectasis, it's a whole host of different causes. Like I said, it could be asthma, it could be COPD, emphysema. Heart disease is a very common cause of shortness of breath. So a lot of different things. AVM is that arterial venous malformation that we discussed, the abnormal tangle of vessels where the artery goes directly to the vein without any intervening capillaries. All right, this one I'm going to have to read for a second. 80 years old, Xarelto, so that's a blood thinner for people given for AFib or blood clots. Have NTM, bronchiectasis, Pseudomonas, coughed up 150 cc's, hospitalized 8 days for stabilization, doing just airway clearance, followed up every 6 months. I don't know what the question is, unfortunately. So maybe I'll move on and perhaps could answer, augment the question. But I'm happy that it hasn't recurred. It sounds like it hasn't recurred. So that's good. Any thoughts on use of other inhaled products or inhaled antibiotics with patients who already have hemoptysis? So yeah, I don't think the hemoptysis necessarily changes what I do for patients with bronchiectasis so much, other than anything specific for the hemoptysis. So if they're candidates for inhaled antibiotics, by all means, they should get them. If they're candidates for chronic azithromycin, yes. If they're candidates, well, almost everyone is, for airway clearance with a vest or a acapella or aerobica or hypertonic saline, all those should be done. And anything that prevents progression or slows progression of the bronchiectasis is likely going to make the hemoptysis become less likely to become a severe problem. All right. Tranexamic acid and it stopped the bleeding. Yeah, you got to take it with a grain of salt. The surgeons have a saying, all bleeding stops eventually, which is somewhat ironic, obviously. But patients, the natural history of hemoptysis is usually for it to stop. The inhaled tranexamic acid may have helped. The literature says there's probably some role. It's not a miracle cure that it's going to stop with everybody. But yeah, on average, if patients have severe persistent hemoptysis, they're in the hospital, tranexamic acid is something to try. The risk of using it, like anything else, you can be allergic to it. I would be most concerned in patients with coronary artery disease or cerebral vascular disease, where promoting clotting could potentially cause a heart attack or stroke. But that may be more theoretical than something that commonly happens. Do exercise or extreme cold temperature cause hemoptysis? I've not read anything about either. In theory, I guess exercise could, because it causes increased blood flow and increased pressures in the pulmonary vasculature. But exercise is so good for you and so important that I don't think I would ever tell anyone not to exercise just because they've had hemoptysis, unless they tell me that every time I exercise, I cough up blood. Then I might reconsider, but that has I've never heard that. Can stress cause hemoptysis? No, not unless that stress is making your blood pressure go up. Overvigorous lung clearance? Potentially, yes. Should antibiotics always be prescribed for bleeding? That's a really good question. You know, we just assume in many cases it's an exacerbation. We all believe that sometimes it's not, probably many times it's not, but we don't have a lot of things in our armamentarium for a patient who doesn't have severe hemoptysis. So very often, clearly if a patient says, you know, for a few days I was having increased green sputum and more volume of it, and they start coughing up a little bit of blood, absolutely they're going to get antibiotics. But let's say it comes out of the blue, you know, for days prior to that, no cough, no sputum, I would probably not give an antibiotic, because I think the chances that it's going to benefit are quite low. Heavy breathing, I doubt it. The exercise, we talked about the increased pressures, but again, it's not a pattern that I've seen commonly. What antibiotic do you use? That depends upon what bacteria. So for my patients with bronchiectasis, I get cultures routinely at least once a year if the patient is bringing stuff up. And so that way, when the patient needs an antibiotic, I sort of have in mind what bacteria they're growing and treat accordingly. If you're having severe bleeding waiting for EMS, is it acceptable to lean the body towards the floor? No, that wouldn't really, unless I see what you're saying. You would have to have your chest higher than your head, which I guess you could, in theory, do that. If you know where your bronchiectasis is worse, the right or left, then I would certainly put the good lung up. And if it really is severe and you can get your chest higher than your head, I've never been asked that question, or it's never come up, but yeah, seems like it's a reasonable thing to do. Coughing up blood further damages the lung, not unless it's leaking back into the lung on a regular basis. So over many years, blood in the lungs can cause scarring, but I've never seen that from a patient who doesn't have a disease that causes them to pretty much bleed into the lung tissue every day. I've never seen it from bronchiectasis. Yeah, so right, it's paradoxical, right? We're saying stop the airway clearance if you're coughing up blood. I would say if you stopped it forever, yes, but stopping it for a few days, no. I think, we always have to weigh risk and benefits. I think the key thing in this kind of, in this setting would be to stop the bleeding. Recommended tests for thoracic endometriosis. Good question. I mean, I would start with a CAT scan. And a biopsy would probably be the next way. But if historically you're a female and you're premenopausal and you cough up blood or have chest pain or pneumothorax, collapse of the lung, that is during your period, that's the clue. And so I would keep a calendar if you have a concern that that's the case. And if it's happening when you're having your period, then you may not even need a biopsy. The diagnosis may become pretty clear, if you put that history together with the imaging. How frequent is it for particle embolization to go to the spine or brain? It's rare, but it can happen. Usually it happens if for the spine, if the blood vessels are of a very unusual pattern and they can't get the catheter far enough in. It used to be a bit more common when this was sort of a new procedure back in the 90s and 80s. It's very rare now, but it can be catastrophic. If it goes to the spine, you can get paralyzed below that area. So you always have to weigh the risks and benefits. If it's going to your brain, that's unlikely unless you have an AVM, that abnormal connection between the arteries and the veins. That would be more unusual. But the spinal stroke, yes, that has happened. I'm going to hope that it was many years ago because it really should be extraordinarily rare these days. I would hold off exercise if I'm actively bleeding significantly, unless it's occasional blood tinge and that's just the way you are, in which case I would say exercise. But if you have a worsening of your hemoptysis, I would probably hold off for a few days until it got better. I'm not aware that positions would aggravate it or cause it. Mucinex, not a lot of evidence in support of it, but I'm not aware of any evidence that there's harm. So I tell patients, I don't generally recommend it, but I tell patients if they think they feel better with it, by all means, go ahead and do it. I think this was already asked, so multiple episodes, generally not, unless it's sort of a other type of condition where patients are bleeding directly into the lung. Does long-time albuterol? No, albuterol will not make bronchiectasis worse. What is considered recurrent hemoptysis impairing quality of life? Well, quite frankly, airway clearance isn't that much fun. So the lack of ability to do airway clearance isn't directly causing impairment of your quality of life. However, it could lead to more rapid progression of the bronchiectasis. So when I say impairment of quality of life, meaning something that makes your life less enjoyable. So if I have a patient who every once in a while coughs up a little bit of blood, it's not physically hurting her. But if she lies awake every night worrying about it, that's impairing her quality of life. Whereas a different patient with the same amount of blood who just doesn't care, it's not bothering them, it's not hurting them, doesn't give it another thought, every once in a while coughs up a little blood-tinged sputum, it's not impairing that patient's quality of life. I think I answered this one. Should you take antibiotics every time? It's often going to be prescribed, but probably isn't always necessary, but it's hard for us to tell sometimes. And I would defer to your physician. So if you cough up 3 tablespoons of blood once, and it doesn't continue, I would say I'm going to hedge several days. There's no right answer to that. No one knows the answer, but I would certainly give it a few days after it stopped. Can hemoptysis be healed? I assume you mean by that permanently fixed. The closest thing I would say is the embolization to clot off those vessels, or removing the area of lung that's bleeding. For most patients, healing probably isn't the right term because it happens once from whatever reason. It may not happen again for 6 months or a year. But certainly if it's a regular thing, those are really the only 2 ways to completely get rid of it. Phage therapy. Interesting. I enrolled the second patient in the current phage therapy study, the second patient in the country. If you have less inflammation, perhaps the hemoptysis will improve. I'm not going to go out on a limb and say getting rid of the Pseudomonas will definitely make. First of all, we don't know the phage will do that. We hope. But it's hard to be sure. You know, when that abnormal tangle of vessels occurs, it may stop going, you know, it may not go away completely, even if you magically could get rid of all the inflammation. 1/8 of a teaspoon of blood, I would still stop until the blood stopped. So that may be a day or 2. It probably means that you do have those abnormal vessels if you're coughing up every 2 to 4 years. But obviously not with horrible sequela, because it's rare for you and it's not that much. Because things will get worse without airway clearance. So it can cause a temporary episode of hemoptysis, but then may go away and not recur for months or many months or years. In the meantime, if you're not doing airway clearance, you likely are getting more mucus plugging, more infection and inflammation, and the cycle gets worse, and then you ultimately may have more hemoptysis. The answer is oscillations of Avess. In theory, yes. Well, it makes sense to me because most hemoptysis stops. Stopping the inhaler was not likely the cause that the hemoptysis stopped. Yeah, if you can nebulize saline, but that by itself is not going to cause hemoptysis. But if some people just can't tolerate the saline, they have severe cough from it. And, you know, so if you're like that and you have severe coughing and it stirs up hemoptysis, then you may not be the right one for the saline. If 7% makes you cough, but 3% doesn't, then you could try the 3%. But the saline doesn't directly cause the hemoptysis. It's the coughing that it might stimulate.
All right, Dr. Metersky, I'm going to have you take one more question. We'll make it a good one. And then we'll close out our webinar today.
All right, so I get to pick the best question. All right, so do we have a lucky winner? Let me see.
That way I don't have to be the bad guy.
How does bronchiectasis get worse? Because I'm going to take that one. It's not a hemoptysis question, but it's a probably global interest. Because whatever was causing you to have that damage to your lungs and chronic infection, once you have chronic infection, it can and inflammation, other airways can get involved. So especially if you have an underlying cause like a genetic defect or a deficiency in your immune system. And I'll give a bonus. A dime-sized clot by itself is probably not going to block anything.
Awesome. Well, Dr. Metersky, I cannot thank you enough for spending some of your time with our community today. I know they had tons of questions. Everyone was really engaged and wanting to find out more. This is a hot topic in both communities. Again, to the community, want to thank you for joining us today. If you aren't a member, we encourage you to join Bronch and NTM 360 Social and NTM Connect communities. We welcome patients, caregivers, and healthcare providers to join the communities and keep the conversation around bronchiectasis and NTM lung disease going. Lastly, on behalf of Bronchiectasis and NTM 360 and NTM Information and Research, we would like to say happy World NTM Awareness Day, everybody. Thank you again for joining us, and we'll see you next time. Thanks, Dr. Metersky.
My pleasure. This was fun.
All right.
I hope
Bye-bye, guys.
people learned something.
Bye, guys.